We saw at the beginning of this module what a guideline was, and that in general, adults are separated from children and adolescents, not only considering the diagnosis, but above all concerning the initiation of the treatment. You've just seen the guidelines for children and adolescents. We will now review those for adults. It is important to point out first that many adults have not been diagnosed before and will often have been treated for other reasons. An adult will go for a consultation for several reasons, ranging from my child had just been diagnosed with ADHD and I think I have the same thing as him, to I think I have this disorder after having looked on internet, or even I have problems to organize myself or to be concentrated and I wonder what it is. Others, on the other hand, will come because they have been diagnosed with ADHD as a child or adolescent. They want to continue their treatments. Others were diagnosed in childhood, then stopped their treatment in adolescence and come to consult because they are in difficulty in their new way of life. It is important to consider these different life trajectories. First, because it will not be the same thing to take care of an adult who has never been diagnosed before than another one who has been diagnosed in childhood. Some adults not diagnosed to date will sometimes be shocked by the diagnosis. Indeed, knowing that you have a disorder for which there is a treatment and that all these years you had to do without can sometimes be very difficult to hear. It will therefore be a question of surrounding them, highlighting their strengths before discussing the implementation of the treatment. If you are a caregiver, do not forget to deconstruct the myth that we saw during the first module. Do not forget to explain what ADHD is to the patient and to the relatives. To understand what one suffers from and to be able to explain to oneself and to the others why one reacts in such a way is already in itself a treatment for the disorder. So you will tell me, but once we know that, what do we do? Well, we have to make the diagnosis. The diagnosis is based on the DSM-5 criteria that you have seen in the module 1. Some of the symptoms should be found before the age of 12 and should impact in at least 2 domains of the life of the subject and cannot be explained by other things. By other things, here we mean the differential diagnosis that you will see later in this module. Reviewing the medical history is very important at this stage, which will also allow you to know if there are any contraindications in initiating drug treatment for ADHD. It is always necessary to surround yourself with the opinion of relatives in order to highlight any unconscious adaptive mechanism that the person has put in place over the years. Think of the high intellectual potential, which can be a mechanism masking attentional difficulties. Questionnaires completed by the evaluator, the person himself, or relatives are really recommended. Don't forget that even if the symptoms can decompensate during stress, you must be able to trace symptoms continuously, even at low noise, indicating that the neurodevelopmental nature of the disorder. It will also be necessary to assess the existence of comorbidities, as you will see in the rest of this module, some of which must be treated as priorities, such as bipolar disorder. It is important to investigate the person's lifestyle, sleep, eating habits, physical activities, use of screens, use of psychoactive substances. Indeed, an intervention aiming at reducing bad habits can, in mild cases, ADHD without complications, only slightly impacting the life of the person who suffers from it, sometimes be enough to allow the person to endure their difficulties without medication. It will also be necessary to look for emotion dysregulation, which is not uncommon in adults with ADHD, and to be interested in the psychosocial aspects and interpersonal relationships, which are often undermined by ADHD. And these guidelines, do they talk about care? Yes. So first you have to psychoeducate, so to know what ADHD is. That's the basis. Talk about the consequences of ADHD if not treated, risk of accidents, legal problems, school, professional failure, family conflicts, comorbidities, substance abuse, and so on. Then you must propose a so-called multimodal treatment plan, including environmental improvements adapted to home, school, work, and relationship, skills training like coaching, and psychopharmacology. Psychosocial intervention and you will see them in the modules 4 and 5, include, among other things, behavioral and cognitive approaches, purely behavioral coaching style interventions, but also training in social skills and teaching skills to close relatives. Mindfulness type approaches can also be offered. Regarding drugs, the first line treatments are the psychostimulants and the second line are the non-psychostimulants. Finally, there are other drugs options. You will see all this in the next module. It is important to target the most disabling symptoms and to regularly assess the response to treatment and modify dosages and/or molecules according to the symptomatic response or side effects. In addition, it will always be a question of evaluating the relevance of whether to continue the medication or to evaluate the need or not of a more intensive psychotherapeutic approach of cognitive behavioral inspiration. The winning combination, really, is combining psychosocial intervention and medication. In case of non-response to treatment, it will be a question of reassessing the diagnosis and asking the question of the differential diagnosis. The therapist will have in mind during the follow-up, once the treatment has been established, the events that can disturb the person and his or her treatment and anticipate them. Change of place of life, of school, of work, birth of a child, divorce, loss of a job, comorbidities, accidents, and so on. There are very few studies on ADHD and the persistence of this disorder in the elderly. But it is also important to recognize this disorder in this age group because it can be a source of distress and suffering if not treated. Since the presentation of ADHD can look like cognitive problems or an underlying depression, one must be particularly vigilant in these cases. As you will have understood, the guidelines relating to ADHD in adults offer individualized treatments, and the patient will have the choice between various psychosocial and psychopharmacological approaches. The best possible care should ideally avoid the negative consequences of the disorder in adults. You will now see what comorbidities and differential diagnoses are.